Hey, it's Adam Sewell, MD. We've talked about the science of the SignalOME, how A2M hyaluronic acid and PDPC form the regenerative triad. Now let's walk through exactly how to build a therapeutic SignalOME protocol for your patients, step by step, just like we do in clinical practice. Everything starts with mapping. Before you inject anything, you need to know what kind of noise you're dealing with. This means assessing inflammatory dominance. If you can, measure synovial markers like interleukin-1 beta or MMP13. If you don't have access to that, use clinical signs. Morning stiffness, heat, and swelling usually indicate cytokine overactivation. The goal here is to understand which SignalOMES or signaling clusters are dominating. Are we looking at a classic inflammatory signal sum or more of a fibrotic one? This guides your first intervention. Once you've identified that inflammatory dominance, the first move is the reset. That's where A2M comes in. You perform an intra-articular lavage or direct injection to bind and neutralize destructive proteases. Within days, patients often notice a deep relief, not just in pain, but in joint pressure. That's your cue that the catabolic signaling has been silenced. You've turned off the alarm. Step 3, the structure, hyaluronic acid application. Next, it's time to rebuild the communication highway. That's hyaluronic acid. Injected intra-articularly to restore lubrication and matrix structure. It also sets up a hydrated environment that allows growth factors and microRNAs to diffuse correctly. This is the resonance stage, where you reestablish the tissue's ability to feel and transmit mechanical and biochemical signals. Step 4, the conductor, PDPC administration. With the joint environment quiet and structured, you're ready for the final phase, PDPC administration. This can be done as an intra-articular injection or combined with PRF for sustained release. What's happening now is a full reorchestration of the joint's molecular environment. TGF-beta and IGF-1 pathways light up, SOX9 re-expression begins, and collagen type 2 synthesis accelerates. Patients often start describing a sense of lightness or improved motion within weeks. That's not placebo, that's cellular re-education. Step 5, reinforcement, biophysical modulation. Regeneration doesn't stop when the injection ends. To reinforce the new SignalOME, I recommend integrating pulsed electromagnetic field therapy or frequency-specific microcurrent. These technologies support mitochondrial coherence and help maintain the regenerative state. It's like keeping the orchestra in rhythm after the conductor leaves the stage. Step 6, reevaluation and imaging. At around 8 to 12 weeks, we reevaluate. Clinically, we look for improved range of motion, reduced swelling, and changes in pain behavior. If available, repeat imaging can show increased cartilage thickness or subchondral bone density improvement. But the most meaningful marker is function. If your patient can do something they couldn't do before, you've changed their biology. Takeaway: to summarize the therapeutic SignalOME process, first, identify the dominant inflammatory or fibrotic signature. Second, reset with A2M. Third, structure with hyaluronic acid. Fourth, conduct with PDPC. And finally, reinforce the new equilibrium with biophysical modulation and follow-up mapping. This is precision regenerative medicine. Not guesswork, not magic, but applied molecular physiology. Closing. In the next episode, we'll look at real patient examples, before and after cases, imaging changes, and measurable biomarker improvements, so you can see exactly how the SignalOME model performs in practice. I'm Adam Sewell, MD, and this is the Regenerative Orthopedics Masterclass.